All right, working our way down finally to the gonads. Now, just so happens...
I think we missed somewhere in between.
I got adrenal. Let me see we did...
That's something that looks like erected penis. Pancreas!
Pancreas! Oh, I don't even want to go. We're going to do pancreas in a second.
All right.
Hi, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Timur Gusov. Welcome to the show, Tim.
Thank you so much for having me. Yeah, it's a pleasure.
Tim is a medical endocrinologist, and I have a special affinity for medical endocrinologists since I'm a reproductive endocrinologist. You'd say, what's the difference? Well, we overlap. We have a lot of overlap. We're both endocrinologists. You tend to see things more from an internal medicine direction. I see things more from an OBGYN reproductive angle, but we're both endocrinologists, and a real pleasure to have you here today, Tim. A medical endocrinologist is someone that has done a full 3-year residency in internal medicine, and then generally does another 3-year fellowship in endocrinology or medical endocrinology.
Usually 2 years is enough.
Usually 2 years.
For the fellowship, yeah.
Mm-hmm. Now, you may be able to tell Tim has a very slight accent, and I can tell you English is your second language. I have a real respect for that. I've lived in Europe and lived in France and speak some French, and I can tell you how difficult it is to not just communicate, but be able to communicate on a high level in a second language. So I really respect that, and it's really amazing you can do that.
Well, I'll be honest, some of the jokes I still don't understand.
The jokes.
Things like cold turkey or, so can amaze me,
And idioms, expressions that you may not be aware of.
Dropping ears, all that good stuff, yeah.
Right, good. Well, Tim, as I told you before, this is a long-form podcast. I'm not here for clickbait or short little snippets. I'm here to discuss issues that people can really sink their teeth into. There's an idiom.
You're right, thank you.
A deep dive in a topic so people can really learn and educate themselves. So today we're going to talk about endocrinology in general and some of the basic things that endocrinologists do. And then we're going to talk about topics that are really the hot topics. We're going to talk about thyroid, how thyroid disease is treated, because there's a lot of different ways and different patterns of treatment between doctors and between specialties. And then we're going to end up talking about diabetes and obesity and all the new medications that have come out that treat both diabetes and obesity. Does that sound like a good plan?
That sounds like a wonderful plan, yes.
Excellent. So, endocrinology has to do with hormones that are frequently made in a certain organ, and then those hormones get in the blood and they go to the rest of the body, and they have tremendous effects. Now, there's also paracrine hormones, and this is where it gets really complicated. These are substances made in cells, and they just go a little ways, and they act maybe just a couple cells away. And then there's even autocrine. So you've got endocrine, paracrine, and autocrine, where cells will make compounds that come back and affect themselves. So it gets really complicated really fast. But let's talk about basic endocrinology. We have a master gland under the brain called the pituitary. It does a lot of fascinating stuff. But the front of the pituitary controls 5 of our basic hormone systems. And I'm going to go head to tail, so I always go in order so I don't forget. The pituitary controls the thyroid gland via something called TSH, thyroid stimulating hormone. And by measuring TSH levels, you can get some idea what the thyroid is doing. The front of the pituitary also controls lactation. It's more important in women, although if there's abnormalities of what are called lactotrophs here, it can affect a man's hormones. Working our way down the body, the liver is here. The liver responds to something called growth hormone, and growth hormone's a hot topic very important in health, and hopefully we can talk about that briefly. Then there are the adrenal glands. These sit on top of the kidneys, and these are the master glands of our immune system and our shock and survival, fight and flight, immune. It's just incredibly important, the adrenal glands. And then last but not least are the gonads, the testes or the ovaries, and the brain controls them as well. And the brain and the pituitary are talking back and forth. It's called crosstalk, and very complicated, very intimidating. And in fact, when I was a medical student, I found endocrinology very intimidating. It's hard to me to believe I actually became an endocrinologist.
When I was in school, my teacher came to the lecture with a big, thick book. And the book was about 18th century Europe, something nice town. And the book was about the doctor. And the first patient was a young, nice gentleman who was a father, very nice, good father, and so on. And at some point, for some reason, he started behaving crazy. He was, throwing the things and stuff like this. And doctor diagnosed him with a hypothyroidism. And he gave him what we now call desiccated thyroid, or extract of the thyroid gland. And that gentleman became himself after the treatment.
He got better.
And my teacher showed us the book, and she said, that's the story of the first 8 pages. And the rest of the book, she closed the book. He's a rich doctor.
Because he did. Now, did he discover desiccated thyroid? Did he invent it?
No, it wasn't. No, I don't think so. It was kind of somehow already available, but he was able to diagnose and appropriately kind of prescribe that. I don't know if I can call it medication, but some
sure. And in fact,
substance,
desiccated or dried out thyroid from beef or pork is currently still used. It used to be called Armor, if you could get it. Nature Thyroid. There's several preparations that actually come from dried out animal thyroid.
Right. Maybe about 70 years ago when we were able to make 100% human hormone. Before that, we were dealing with, just like you mentioned, the pork or the any other cattle's kind of thyroid desiccated things. And it was a struggle because, you take the thyroid gland, you dry it out, you chop it into many, many pieces, and then you hope that whatever you give have the same amount of hormones, and you hope that would somehow help, and every gentleman will become, a normal after that medication.
Yeah.
And so you control, you do the blood test, and sometimes it works, sometimes better, sometimes no. This is in range, a little high, a little that. And then, just like I said, about 60, 70 years ago, we finally have a human, 100% identical. Yes.
A synthetic, measurable, reproducible dose.
Human levothyroxine. Yes. I'm going to say something very controversial.
Please.
Why do we still have the pork thyroid?
Right.
Is a big question. And I don't understand. And I see a lot of these people, they say, it's natural. I'm not sure if the pork hormone is natural for human. So many troubles we have with that, because the levels are still kind of the problem. I guess the main big thing about that is the pork, a pig, instead of the humans. The thyroid gland makes not only T4, but also T3.
Right.
Just like the human. The human makes 99% of T4 and just a little bit of T3. And believe it or not, every cell in the body in the human body, picks up that T4 and converts it to the T3.
Right.
As much as that cell think it needs. That's only God could create.
And that's where the controversy starts. So let me back up a tiny bit. So let me
finish. And at the same time, the pork produced 75% of T4 and 25% of T3.
A lot more T3.
25, right. A lot more. And so even from that perspective, it's a kind of, and I don't, yeah. And we see all these kind of different, all these a little bit discrepancies. The TSH is this way, T4 this way, T3, and so on, and so on. And yeah. Sorry, you
no, this is great. This is great, and you're really highlighting where a lot of the controversy is. You've got let's say the party line, the standard medical, how we're trained to use T4 pretty much only, and then the alternative forms. So let me back up for our audience. Low thyroid is very, very common.
Yes, it is.
It's very, very common. One of the causes of it is that the body's attacking the thyroid gland, something called Hashimoto's. Sometimes there's nutritional deficiencies. I know people talk about general inflammation, perhaps, maybe not even specific antibodies for the thyroid, but maybe general inflammation. Can you think of any other? And sometimes people have had their thyroid taken out for tumors or cancers. Yeah. And sometimes a person has had very high thyroid. The thyroid's been overactive, something called Graves' disease, and it's been treated with radioactivity. So now they are hypothyroid. So you can become low thyroid any number of ways. And so we treat now in reproductive endocrinology, low thyroid can cause infertility or contribute to fertility. So I treat a lot of low thyroid. Now, let's talk about one controversy right off the bat. A lot of the old-fashioned doctors will look at a hormone called TSH only. TSH is made by, that's why I mentioned the pituitary. It's made by the pituitary. Yeah. And the thought is, if the pituitary is sending down a normal amount of TSH, then the pituitary is happy with how much thyroid is coming out of the thyroid gland. So some doctors treat TSH only. Most of the time nowadays, I will check a TSH and what's called a free T4, so I know how much thyroid hormone is actually in the blood, so I can kind of interpret the two. And then there's some doctors or practitioners who will be checking T3, they'll be checking reverse T3, they'll be checking all these other thyroid hormones in the blood. So in your experience, Tim, what's the most common cause, or what are the most common causes of low thyroid that you see all the time?
Right. This is the most common. No, I'm going to take it back. It's the. Yeah, I'll say this is the most common endocrine medication, the levothyroxine.
Okay.
And the Hashimoto's is a very, unfortunately, popular, very, very common condition worldwide. Regardless.
And it may be more common here in the Midwest, Tim. I don't know. I've heard it is, maybe because of things in the environment.
That is correct. Some radiation waste, radioactive waste, and something St. Louis, and people don't talk much about it.
Yeah, they don't.
Some of the
St. Louis in the 1800s was a chemical town. I'm not going to say the name of the company. It was an enormous chemical town, and there was spillage and waste and things put in the water that they didn't talk about.
Some of the providers mention that it's actually even common in pets, like cats.
In pets, even pets are getting low thyroid.
Yes,
I'll be darned.
Yes. Yes, and for some reason, really kind of we don't really know the cause of that, but for some reason, immune system decided to fight the thyroid and kind of destroy it.
Right.
And you can, I guess, bring a lot of hypothetical kind of causes for that, but really, bottom line, we're not sure why.
Okay.
Yes, iodine deficiency is another problem, but just like you, I think you mentioned that in some of the countries, United States and Japan, the countries where the iodine is the highest in the water.
Okay.
In United States specifically, it's mostly on the coast, east and west coast. In Midwest, especially somewhere in some of the towns here in Missouri, the kind of iodine in the water is not really much, but we put it in the salt. So as long as you buy iodinized salt, you're good.
So low iodine in the United States, fairly rare. It can happen, but it's fairly rare.
Right. It's more common in Eastern Europe, the country I'm from, and some of the African countries, and China, yes.
And in China, that's right. Now, how do you diagnose hypothyroidism or low thyroid? How would Dr. Tim Gusov make that diagnosis?
When you diagnose any disease, you look for the clinical signs and biochemical confirmation. So you look for the clinical and a biochemical confirmation, just like I said. And so, but unfortunately, when we're talking about the thyroid, the clinical picture is very, very. My teacher used to call it. The thyroid is like a monkey. You can never figure if it's real or not.
Right, because it's so vague and global and non-specific.
And non-specific would be a very appropriate way to call it, because the low thyroid will give you a little bit of fatigue. And I mean, how many people nowadays?
Right. How many things cause fatigue?
Right, and maybe sometimes you can have a hair loss. I mean, how many people have a hair loss?
Right.
And I guess the reason of the thyroid cause will be number 20 something.
But it's in there.
But it's there, right.
And a little bit of weight gain. Right. What causes weight gain? Right. And millions of things. So it's non-specific. So if you were to do some blood tests, let's say somebody walks in, they have some symptoms of thyroid. What blood tests do you like to get to evaluate the thyroid?
You're right. There are a few of them, and TSH, 3T4, and 3T3 would probably be the kind of most common things.
So you would get it. So you would get even a free T3.
Well, I didn't say that. So just like you say, we have something like a normal range, and all of them should be in a normal range or something like this. Right. And which one of them should be the most best, just like my friend used to say. The main hormone you want to look at, and that would be TSH. If you have a healthy pituitary, that's a very important thing.
Right. That is so. Let's put a fine point on that. By measuring the TSH and interpreting it, you are assuming the pituitary is working.
Right.
The brain is working.
Yeah.
They're not taking in any other hormones. That it's a valid value in the blood. Okay.
Right. And even if you look at the result on the paper, it says 3T4, 3T3, and third generation TSH.
Right.
What is it that third generation even means? That means that the TSH is the most accurate test out of those three. So sometimes you can, if you have some friends in the lab, they can tell you a little bit more about the accuracy of the test, the T4 and T3. T3 is probably most unreliable.
Okay.
And T4 is kind of okay, but the TSH is it's a very, very accurate as much as the.
So I'd like to hear your thoughts.
With the tiny exception before, the test kind of based on use of the biotin. So if somebody takes the biotin for any reasons, the patient takes biotin for, I don't know, the hair and nails,
like a vitamin or supplement, biotin. Okay.
That will probably interact with the test, not the thyroid levels, not the work of the thyroid, not. Yeah. But just on a test when we're going to run it in the lab, that can kind of interact a little bit with the analysis and make the TSH look lower than it actually is.
Okay, very, very interesting. Good to know. Now, I want you to talk about the concept of normal and optimal. Now, let me explain to our audience what I mean. Almost everything in the world has a bell-shaped distribution. There's average height, and there's just a few people who are super tall, and a few people that are super short. But height among almost everything in the world comes in a bell-shaped distribution. And what we call the inside 2/3, roughly, we call normal usually. However, And what went on for many years is if a person's TSH was between, let's say, 0.7 or around 1 and up to 4.5, that was the normal range.
No, it's not the normal range. It's a normal range. So 95% of the people will have that range. Yeah.
Right. So you're following me. I want the audience to follow me. However, in that normal range are sick people. And the question is, if a person's TSH is in the normal range, is it in the healthy range? Like if you were to take the sick people out of there, normal's going to shift. So a lot of doctors will say, let's say normal is up to 4.5, 4.5. And a lot of, I would call them the old-fashioned doctors, say, hey, your TSH is 4.4, just under, therefore you're normal, therefore you're fine. Whereas some new thinking is, well, it may be in the normal range, but it's not in the optimal range. And you'll see people talking about TSHs, particularly in the fertility world. Well, maybe we want the TSH less than 2.5 because I don't care what normal is. I care what is normal for a healthy population. So what are your thoughts on interpreting TSH as a medical endocrinologist?
So it's, I guess, important to understand that 95% of the people with a healthy thyroid and healthy everything else, will have the TSH somewhere between 0.4 and 4 point something. Right. Depends on the lab and stuff like this. And that is an absolutely healthy level. Sometimes those other 5% of the people will come with lower TSH and higher TSH, right? Especially, as we getting older, those kind of levels can be sometimes tricky. But again, if it's just a kind of deep and a little complicated question. So if we talking about a treatment of the hypothyroidism, for example, Hashimoto's will be most common, then we're looking into normalization of TSH. And the question is, what is normal? How would we know what was TSH before the disease?
Right.
We don't. And that's where we use clinical trials, right? And there was a clinical trial when they kind of looked into people treated with levothyroxine with the different goals, say TSH of 1, of 2, of 3, and 4. Okay. And the happiest of all were the people with TSH of 1. So I guess the goal of the treatment of people with hypothyroidism, I guess since then, for me as well, would be the number 1, the TSH somewhere around 1.
All right, so you have no problem, even though normal might be, let's say, in the 4s, that there is some data to suggest if you get, and once again, let me explain. A high TSH means generally a low thyroid. Okay, this is something that is called an inverse correlation. But you're telling me there is some data to suggest if you get your TSH closer to 1, the people are generally happier, and we can.
If we're talking about people with confirmed, hypothyroidism, treated hypothyroid, at the same time, if it's a healthy person, and I see it a lot of times. If it's a healthy person who, for some reason, end up in a stress, emotional stress, I don't know, some relationship troubles or overwhelming physical activity or something like this.
Okay.
That TSH can sometimes kind of be a little bit higher or lower or something like this.
Sure, it's adjusting to the body. It's called homeostasis.
Right, a little bit. And if you recheck it 3-4 months later, when the the motions are done and you feel much better, then the levels are usually going back to normal.
Okay.
Unless there's another thyroid condition going on, thyroid disease.
Okay.
But unfortunately, some providers see that the patient will come with some feeling of something,
right?
Like tired, gaining weight for no good reason, and so on, and they say, it's your thyroid. And regardless of the TSH, especially if the TSH is a little bit on the high side, they give them the thyroid medication. And unfortunately, the patient has to take that medication for the rest of their life with no good reason. And
Well,
if
they could.
would be right, and okay, what's going to happen? Okay, she will just replace a little bit of function of her thyroid. But the problem is they just don't feel any different.
Right.
Like,
and how much improvement would be placebo?
Right. So it's never just the numbers. In the human body is a complex kind of, very complex and beyond our comprehension mechanism. And instead of dropping, before you want to give somebody any medication, really, you might want to know for sure, especially if that's the medication you want to give for the rest of her or his life, you want to make sure you're doing the right thing, really. So,
right.
Yeah. And I saw a lot, especially young people, especially young girls who would feel emotionally overwhelmed. They got into some relationship and now they're doing, go into the gym so often so they can go into the shape so quickly so they can look better and, and win that heart or something like this. And, and that at the same time they do the blood work and the TSH is a little high and they give him the levothyroxine. Are they feeling better? No, but...
yeah, it's hard since it's vague and if you're close to normal, it's hard to justify treating. And sometimes when I'm dealing with infertility, people are desperate. We're changing a lot of variables. And sometimes I'll say, you know what, ma'am?
It's a different...
It's a safe medicine and it's a cheap medicine. And if I give you a little bit, what's the harm? And if it helps. But I think if we explain that to the patient, I realize that I'm not guaranteeing you need this, but it's something to try.
But there's a good data supporting that it's in a lot of cases that's efficient, that's effective when somebody's looking for pregnancy and the TSH is a little. So it's a little different story,
Yeah. Well, the data is conflicting. It's not clean data by any means.
Right.
So I'm going to talk about one more controversy in thyroid treatment that we've already mentioned.
Please, not the big.
It's going to be Armour and Natured Thyroid. Sometimes you get now the goal, obviously, as you mentioned earlier, is the body's going to take this T4 and turn it into T3 in the cells, and that's really what matters. So when we draw a T4 level in the blood or T3 in the blood, it's not really telling us what's going on in the cells, particularly in the liver where it matters. And I will say that these desiccated animal thyroid products are getting more standardized. The doses are becoming more reliable, better than they used to be. And because I really want you to hear what you have to say, because I see people that are already taking one of these animal types.
Right.
And the rationale elsewhere was, we tried the T4, the synthetic T4. Patients' numbers got better, but they didn't feel better. But we switched to one of these other brands, and the patient feels better. Now, they feel better. Was it coincidental? Or was it due to the switch in the medicine?
Yes.
Hard to say.
No. I have an answer.
Please. That's why you're here, Tim. I want to learn.
My teacher, from the great country of Russia, the leader endocrinologist, Professor Melnichenko would say the trick is in T3.
In the T3, the active thyroid, correct.
Just like I said. In a human body, every cell needs to pick it up and iodinize the T4 into the T3.
Okay.
And if you give the animal product, you give the T4 and an active T3, right? And they feel better. It's because the T3 is just like a boost. It's like an extra cup of coffee. And it will give you energy with the price tag.
What is the price?
What is the price?
Please. I want to know what, because we're going to be talking about that in a little bit. Price tags of treatments.
Just like I usually say about the sweeteners, it comes with a price tag. So is it okay for somebody to be a little bit hyperthyroid
Ah,
in the morning because the active time is about 8 hours, and then the rest of the day would be fine. No, unfortunately, it's not good. It's the God designed the body for a good reason, and so the price tag is higher than it's supposed to be. Levels of the thyroid usually affecting heart. So in the long run, you're talking about maybe premature heart failure or something like this.
Way down the line.
Right. And you're talking about osteoporosis. So those are two biggest things.
But okay, let's say this. Maintaining strong bones is a part of longevity. It is the foundation of the body. And keeping your calcium and protein high and in strong bones is important.
Yeah.
And so you could speed up leaching and degradation of bone. So being a little hyperthyroid could have a long-term effect on bone density.
I'm not into cars. I don't know much about them.
Okay.
But I feel like the turbo in the engine does pretty much the same. It gives you big power.
Yeah.
But as far as I know, it kind of wears out the engine.
Yeah,
fast.
turbo and superchargers, they are not good for the longevity of your engine. This is true.
Right. So, yeah.
Okay, that's a very well thought out reason. So I know the medical endocrinologist, the party line is give T4 because the doses are precise, reproducible, and the body will make the T3 it needs without getting hyperthyroid in the cells.
Let me kind of draw the bottom line and say, yes, synthetic human T4 is the gold standard. And sometimes you do need a little bit of T3. And there is a synthetic human T3 available on the market as well.
The name brand used to be called Cytomel.
Right. Or levothyronine. And yeah, sometimes you just, you can use it as well.
Yes,
So-
and I do occasionally.
Right. Yeah.
Yeah, and I know bodybuilders, when they're cutting, it's one of the part of the gear, part of the cocktail that they take to burn fat and get ready for contests. T3,
Oh, interesting.
Cytomel. Yeah, it's part of the whole. I'm not going to go there today. I don't know enough about it other than to say that it's one way to lose a little more body fat. Okay, so there's our thyroids. Let's move on down. Let's just say briefly, lactation in men isn't important, but the lactotrophs in the brain and the pituitary can sometimes start growing. Women can have irregular periods from that. When it gets bad, they can start making milk when they're not supposed to. And I just want to mention that these benign tumors, they're almost never cancer. These benign tumors of the pituitary are very common, aren't they?
They are common. And I guess it's one of those things in the medicine which we are very proud of, because up until we discovered that medication and we kind of understood a little bit about that prolactin and the tumor called prolactinoma, and we found the treatment of that, we took away people with a tumor, gave them a medication, and not only they got better, that they got cured sometimes,
Without surgery.
Without the surgery.
Yeah, because let me tell people, the pituitary is in the base of the brain. It is an incredible surgery. They go through the mouth and the nose and all. Oh my goodness, what an amazing surgery!
Right.
But that's not a trivial thing.
And I guess
you can mess with all your hormones that way.
And I guess every major endocrine department of universities has a big picture of what's called Destinex baby.
Yes, it's called cabergoline. The generic name is cabergoline.
Cabergoline, yeah.
It's a wonderful drug. You take it once a week. It's very powerful. Does the trick.
Right. So yeah, that's one of the things we're really proud of, and it's a common condition. And sometimes we can even say you lucky because you have that tumor, because we know how to treat it.
Yeah.
And a lot of times we able not only shrink the tumor but dissolve it.
It goes away. They, in fact, can go away. Amazing.
Yeah,
Working down.
Because endocrine is amazing.
It'll be fascinating till never a boring day in the world of endocrine. Working our way down the body through the pituitary, there's a hormone called growth hormone. And growth hormone comes to pituitary, and it acts in the body mainly. It does have some direct activities, but mainly through the liver, and it releases something called insulin-like growth factor. And then that affects the rest of our body in many different ways. One of the most important is keeping muscle mass. And we're going to talk about later how important muscle mass is to our metabolism, keeping our sugars low and our bodies strong and living long. But growth hormone is a very fragile hormone. It's called a peptide, a little protein. It's hard to give it without injection, and is very expensive. And it too can have a price tag if you take too much and whatnot. So, what's new in growth hormone in your world, Tim?
I guess the new one is he finally became the richest athlete in 2017, if I'm not mistaken. Lionel Messi.
Lionel Messi, yes. My little boy loves Messi, yes.
And the reason that Lionel Messi is not so little is because an appropriate time he was treated with a growth hormone.
When he was a young man, maybe not growing enough?
Yes, that is correct.
Wow.
So it's another kind of aspect of endocrine we're very proud of.
Look what we helped.
Right. Where we can change somebody's life to the point that, from the small boy he can be I was going to say rock star, but superstar, yeah.
Yeah, wasn't he just offered over $1 billion to play in Saudi Arabia?
I'm not sure how much.
He was, I think it was 1.2. But his wife said, no. I think he's going to Miami for just a few $100 million, something like that.
Okay.
He can play MLB.
Right.
So how about, I see, it's just amazing. If you do a Google search for growth hormone, all of a sudden YouTube and everybody starts sending you ads for growth hormone. They say it's growth hormone, but it's not. Pills that apparently are called secretagogues. They're amino acids that they say will cause your pituitary to make more of its own growth hormones. And people use this for anti-aging or to grow more muscles if they're bodybuilding or to feel better. Well, do you see much of that, Tim? Do people come to you asking for growth hormone, or do you see deficiencies very often that warrant actual hormone injections of actual growth hormone?
No, I don't think I see a lot of people with that. Most of the hormone deficiencies are covered by somebody called pediatric endocrinologist, so somebody who's taking care of the people when they are younger than 18 years old. And I don't really, they come to me with treated conditions.
Okay.
Sometimes when the people get treated with pituitary tumors and when they have pituitary gland removed, then obviously they have the removed organ, the one that produced the growth.
And you got to replace everything. It's called pan-hypopituitarism.
Right. In that case, you would want to replace the growth hormone, even an adult person who already grew.
You're going to need some.
Everything else. Just like you mentioned, the problem is in the price, and insurance companies are not so much excited to pay.
Right. And it is because it can be abused by bodybuilders. It is a controlled substance. And you can't just buy it at every pharmacy.
Right. The price tag that you mentioned, if you take it too much for too long, then obvious complications are. So it's a growth hormone. So everything grows with the growth hormone.
Yeah. And there's some parts of our bodies that keep growing even after our bones have stopped growing long.
Right. And the major concerns really is the liver diseases and the kind of cancers in the stomach and GI area.
So it can promote some cancers.
Right.
Right. And you can see this.
I should say, sorry to interrupt.
Please.
I should say that the data is kind of little... not too much really Not very clear. Let's put it this way.
It might affect how you process carbohydrates and whatnot.
That is correct.
Could contribute possibly to diabetes.
Right.
But you see this in female bodybuilders in untested class, in these open classes where they can take drugs. You see it. You see their jaws are bigger, their noses are bigger. Sometimes you'll see the forehead is bigger in these women that have been taking growth hormone. It's more obvious in the women. Although you'll see it in some of the men too. I've seen it in some of the professional wrestlers.
Right. Okay.
Who take a lot of drugs too. You'll see these changes to the face and the ears grow too. So some parts of us can still grow. And there's a look to it. Now, you can get a nose job. You can get a chin job. However, it's really hard to see. What's hard is this brow. When you see this brow starting to grow, even after plastic surgery, you can get a little suspicious. You say there's something a little different about that person's face. And that can come from the growth hormone. So what my understanding is these secretagogue pills, they can have some amino acid, some arginine or some nitric oxide donor, and they're supposed to increase the growth hormone made by the pituitary. I suppose it's a little bit, but it's nothing close to the potency of an injection.
There's no really good data to to say anything about it. I guess it does something, but not really. Not sure.
Yeah. Moving on to the adrenal gland. Now, the adrenal gland could control so much. If you have a stress, if you don't have an adrenal gland, you will die. Any type of stress or injury or infection, you will die pretty quickly without an adrenal gland.
That's a very important aspect. But I'm gonna ask you a few funny questions.
Please. I'm on the spot now. I love it.
What do you think a monkey is doing on each other's back?
On whose back?
On each other's back.
They're grooming and preening and eating the little bugs and the lice and touching.
That's just like my teacher say, and that would be the most common wrong answer. No, bugs. I mean, you can find the bugs everywhere, and what a big deal. Believe it or not, but with the sweat, a lot of salt goes to the fur. So what they do is picking up the salt.
Oh, they salt. It's like a salt lick.
Why is it so important? Because salt is life.
Yeah.
What is the name when you come and they give you money? What is that?
It's called a salary.
Salary.
Because the Roman soldiers used to be paid with salt.
Exactly.
Yes.
Exactly. The soldier, the salary, and the monkeys. And there's the salt is life. So one of the things that adrenals are doing is to keep that salt in your body. Obviously, now with the contemporary diet, you have salt everywhere, and unfortunately, now we see a lot of problems with
perhaps too much salt. At least in salt-sensitive individuals, it is an issue.
Exactly right. Especially in some races like African American.
Yes, they're more sensitive. And just in the United States, not Africa. We can go into that, but yes.
Right. It's about genetics. Those are probably even because when you take away the adrenals, I guess the reason you're gonna die faster would be the loss of salt.
Sure, and that if we have a baby, in fact, born with salt wasting, you got to know within hours. You measure sodium right off the bat, and if an infant comes out and the genitals are abnormal, it's called ambiguous genitals. You see that in 1 in 1,500 newborns. What will kill them first is salt wasting, abnormal salt. So that's what you have to measure immediately. Yeah. So it's really, really important. So we need adrenal glands, and there's interesting stories about John F. Kennedy. His face had different appearances because they didn't have good adrenal gland hormone replacement. I think they had desiccated adrenal gland back then.
I was just going to say that. Right.
Tell me, so John F. Kennedy, his face, he had real, true disease or hypo or underactive adrenal glands.
Right, and in different countries, the reasons for underactive adrenals are different. Say in my countries, in Asia is tuberculosis.
Yes, tuberculosis. It can infect and destroy the adrenal gland.
And in here, or so-called developed countries, is autoimmune. So again, just like with the story with the thyroid, for some reason, if your own immune system destroys your adrenal glands, and yeah, just like you said, JFK had that disease, and when my patients come diagnosed with adrenal deficiency, or I usually say, "What do you think you have common with the JFK?"
With JFK, right. For the president, right?
Right. Yes, we on that time did not have a good medication. We probably don't have an awesome medication even now because we know that cortisol, right, secreted kind of in a different speed through the day. So it's on the maximum production when we wake up, and then gradually through the day goes down.
Okay.
And what we're trying to do in the patients, we're trying to mimic, we're trying to kind of reproduce the normal level of cortisol. And so we give them medications 2 times a day. We give them
a higher dose in the morning.
Right.
Okay.
And a lower dose in the evening. But what we end up having is a big peak and a small peak. But unfortunately, we cannot really reproduce the NASM line, which is in a normal person. So this is where, talk about pumps or some infusion device that can kind of reproduce, that infuse your cortisol with the speed that mimics exactly like it is in healthy individuals comes. But I see a lot of work done in Britain about it, and they swear that it's the best treatment. But people with adrenal deficiency taking pills are not so much interested in to have something attached to their body all the time. And so that small difference between the normal and what we kind of do with the medication is really not clinically not something significant. And most of the people with that adrenal disease now live a long, prosperous life and die from something else.
From something else, yeah, that's the goal.
Here's the story with JFK comes again.
Right, exactly.
Right.
So the adrenal gland, very complicated. It makes these glucocorticoids that help us with stress and modify our sugar levels. We've got those that are androgens, and then we have some that involve blood pressure,
right,
and salt control. So the adrenal gland makes a lot of different hormones, and that's just the outside.
Mm-hmm.
And then there's the inside, making
yes.
adrenaline and that type of stuff. So here I want to hit on another controversy. So you see people that have their adrenal gland is clearly underactive, and we have criteria. You give a hormone in the vein, and you see, does the adrenal gland respond normal? If it doesn't hit a certain cutoff, 17 or 20, or you draw the line, then we can diagnose true adrenal insufficiency. How about adrenal fatigue? Underactive adrenal, causing vague symptoms of weakness, not feeling oneself. These people typically, if you give them a test, a corticotricin test, you can get their adrenal gland to make normal levels. Do you see much of this borderline adrenal activity, adrenal fatigue, that people want treated?
There is a great Chinese philosopher. His name is Confuci.
Not Copernicus. Not Copernicus. Galileo, Confucius.
Right.
Not Lao-Tzu, Confucius.
One time he said something very important. It's very difficult to find a gray cat in a dark room, especially if the cat is not there. I don't know what is the adrenal fatigue. I could probably understand if the patient is in a hospital going to ICU on the floor and it's a constant stress that really wears the body out. But if it's somebody young, and there's a little bit of tiredness and a little bit of this and that, and I want some steroids to boost me.
Right.
The problem is everybody will feel much better with injection of adrenal glands.
Yes.
So much so that at some point in United States military, one of the injections, that every soldier would have, other than the narcotics and the painkillers, was the Solumedrol, actually, the
Solumedrol.
medication designed specifically for United States Army, because you can take it and become Hulk, incredible,
Temporarily
right.
boost. Yeah. And in
It comes
fact,
with a price tag, unfortunately, as well.
yes. Yes.
But yes.
Yeah, the price tag of these. Plus, you become dependent on it. You
Right.
have to taper off. You can't, if you've been taking steroids, that's when you take one of these dose packs for
Right.
poison ivy or something.
So
It tapers off.
so-
You shouldn't stop immediately.
So when you compare a story with a thyroid, when you say, okay, let me try, I'll give you the medication, let's see how you feel. And some people say, I feel better. Some people say, what do I have to take it all the time? With steroids, all the time, everybody will feel better, so much more energized. Right. I want to be this way all my life, of course. Yeah. So much so, then according to, my wife and some people from Asian countries, they say, people in the farm, when you come to the pharmacy and complain about something, they say, just take this. This
right.
will make you feel better.
You'll feel better.
And they're right. It will.
Yeah.
So going back to the question, what is adrenal fatigue?
So
I'm not sure. I don't know.
So modern standard medical endocrinology doesn't really recognize it as a separate entity, and it's and very difficult. It's hard to see the gray cat in the dark.
That is correct.
Okay. And I can tell you about steroids. I have bad shoulder and back, and I've had steroid injections for shoulder and back. There is a little bit of euphoria I feel from whatever. I don't know if it's what the glucocorticoid. They're all pretty much the same, just different half-lives and potencies. But I have felt a little bit of euphoria from steroid injections in my back and my shoulders. Subtle, and it's not like a buzz I would call it, but I'm very perceptive to susceptible to these things. And I can feel that little bit of euphoria, and I feel really good, even if my shoulder may not be at the best. So I can tell you, almost anybody, you're going to feel a little euphoria, let's use that word, with these glucocorticoids.
Right, but the price tag is very, very big in here.
Yeah.
Steroids are, a good medication. Sometimes we use it, for, just like you said, for the pain, for the inflammation, for a lot of rheumatological conditions.
Right.
When we, not really certain what else to do.
Right.
But if we use it for some certain amount of time, we see, what's called iatrogenic Cushing disease.
Iatrogenic Cushing's disease, where you start showing signs as if your adrenal gland had a tumor and was cranking out too much.
Right.
And you can see that.
Yeah, and it's very dangerous. The muscles are affected, the bones, the sugar, you develop diabetes, the blood pressure.
Right.
Pretty much every part of your body, from skin to, everything is affected. And
it messes up everything. Right. The pseudo or iatrogenic Cushing's.
Right.
All right, working our way down finally to the gonads. Now, just so happens.
I think we missed somewhere in between.
I got adrenal. Let me see. We did.
It's something that looks like erected penis. Pancreas.
Pancreas. Oh, I don't even want to go. We're gonna do pancreas in a second.
All right.
I'm going strict pituitary here, and the last is the gonads. I want to do the big five.
Okay.
And in fact, the next doctor I'm about to interview for the next podcast is going to talk about hormone replacement in men. Mm-hmm. We've already had a wonderful doctor here. She was talking about hormone replacement in women. We're going to revisit that. But what I can tell you is that there's lots of ads for testosterone. There's a lot of older men and women who want to maintain their muscle mass and their energy level and their sexual libido. And there's a lot of testosterone being given and taken, more so than a person would normally make. Do you, as a medical endocrinologist, do you see much demand or much need or, let's say, indications for testosterone replacement?
Yes, for sure. We used to see something like a primary deficiency, meaning when the testicles, for some reason, testicles would stop making testosterone, or secondary deficiency when the pituitary would stop or slow down with the production of the control substance that regulates the testicles. now we see a lot of what's called metabolic, when the kind of testicles are normally functioning and the pituitary is looking healthy, but for some reason, because of the advanced obesity or diabetes or something like this, the level of testosterone is going down. And you have a choice to either try to reverse the obesity, and you see the effect. The system recovers.
Sure.
Something we see with, for example, bariatric surgeries.
Right. If an obese
like
man gets bariatric surgery, testosterone levels do improve usually.
Right.
And their estrogen levels go down. A lot of gonadal hormones improve.
A lot of interest in the testosterone therapy. Right. A lot of times that medication is prescribed for no good reason.
Right.
And again, what's the harm of that? The harm number one is people just don't feel any different. They just take it and say, I don't. But when you take too much of that, it's not only level on a lab test, but also, higher than it's supposed to be level of testosterone affecting the liver.
Right.
And so one of the main concerns is the liver cirrhosis, liver disease.
Right.
Different. The other one is concern about the heart and the clotting.
And clotting factors. Yep.
Yeah. Right. So some of the people can develop clots, and it's not just that's something very urgent and can cause, acute problems, including death.
Death.
And I guess when we're talking about the young people, and concerns obviously will be somewhere around infertility or,
Oh, yeah. And I say this every chance I get. For guys trying to have kids, testosterone is the worst thing in the world you can take. It shuts down. It's a contraceptive. It shuts down sperm production.
I guess it's not the best contraceptive. It looks
it's
like
pretty darn good. It's just not consistent enough to be branded as a contraceptive. That's the problem, is the consistency.
Right. But yeah, it looks like, let's put it this way. Some of my colleagues do use testosterone. So when you know what you're doing, and when you keep the level very nice, and you take the medication regularly, and if you know what you're doing, or your doctor knows what you're doing, you're fine. You're not going to overdose yourself.
Right.
And there are some medications available that you have to take like once in 3 months. Injection.
Right. Pellets, slow release.
Injection.
Or depot injection.
Depot injection, right. Pellets is a little bit different story. There's not really much to support good levels after that. So, not sure. Right. Just not enough data, really.
Interesting.
But injections, especially in Europe, the medication came from Germany. And now it's everywhere, and came to American market not so long ago.
Is that decanoate or do you Valorate, or do you know the testosterone?
Decanoate, right?
Decanoate, yeah.
Very good medication. Now it comes in an oral medication as well. Right, with the main concern of the high blood pressure. But bottom line, it looks like it's doing the job. And yes, I feel like if you want to take some medication, some endocrine medication or some endocrine hormone to kind of have a better life and stuff like this, and probably testosterone is one of them. At least that's what they say about one of the president of the biggest country in the world. And he started the war because he was overdosed with one.
Yeah. Hey, and there's some thought that Hitler was addicted to amphetamines and might have contributed to his crazy things.
I don't think it's I think it's a very confirmed fact, really, about the Hitler.
Yeah. So when I'm getting back to testosterone here, what I'm feeling from you here is there's no horrible red flags if done appropriately.
If done appropriately, would be
that a lot of people are doing it. A lot of people are feeling better. They're maintaining muscle mass. And I'll just say again, if you're a guy and you've finished childbearing, you don't need any more sperm cells. Definitely something that will. And we're going to talk about that again in another podcast. That's great to know.
And again, I feel like I want to kind of empathize on, make a very good stress on making sure that you know what you're doing and your doctor knows what they're doing and keep the levels and everything else. And that medication seems to be is a safe kind of thing to do.
Great. So now I saved the best for last, Tim.
Da-da-da-dum.
Type 2 diabetes and what goes along with it, obesity, particularly the centripetal obesity that I fight with, the inflammation that comes with it, the metabolic syndrome that comes along with it, these higher and higher blood sugars, high blood pressure, things that contribute to vascular disease, heart attacks, strokes, all these bad things that come with the eventual result of diabetes and organ failure. And I'm going to interject something here. We are not logical creatures. I remember seeing a show on plastic surgery years ago. It was a guy complaining about the scar on his arm because he went to a plastic surgeon where they inserted a bicep balloon, a silicone bicep balloon, so that he would have so he would look better in a shirt with a bigger bicep. And this is thousands of dollars. It's something in your body that can get infected, right? It does absolutely nothing physically. And I remember watching the TV going, why aren't you spending those thousands of dollars on a premier gym membership and a trainer and build some functional biceps, right? So here you are complaining about this scar when you've put this foreign body in you. That's not logical. Doesn't make any sense. So we don't do things necessarily logically. I've seen these things recently, my feed on YouTube. These electrodes, these 6-pack electrodes. Looks like a spider or something. And there's these electrodes, and you put them on, and you can just sit there, watch TV, I guess drink a beer or whatever. And it goes, and you do 1,000 sit-ups, right? Why don't you just do it? Why don't we do the 1,000 sit-ups? Well, it comes down to we go by urges and satisfaction and these internal cravings and desires that are hard to put your finger on. But these things, why we make these decisions and how we seek comfort and comfortable sensations kind of overrules any logic. So, takes us to type 2 diabetes and obesity. We also have it pretty crazy here in the United States where fat was vilified and everybody thought fat made you fat and fat gave you diabetes, and nothing could be farther from the truth. And our whole country was told to eat a food pyramid based on grains and carbohydrates, and our whole country has exploded in obesity and diabetes. And rather than say, hey, look, we were wrong, we should be living on meat and fat and not all these carbohydrates, they said, well, we can have all these medications now. One of my favorite ones on TV right now, I want to call it Giardia. Giardia is a parasite. You get it from bad water and you lose 50 pounds from diarrhea and being sick. But it's called Giardians. I see it on TV, and it's got this diabetic woman dancing, and she's all fun. And the medical establishment will say, hey, if you don't eat carbohydrates and you lower your blood glucose, oh, that's bad. Oh, but you can have a pill where you can pee out all this sugar and get infections in your genital tract. And because it's a pill, it's just fine. And they ignore the fact that we're addicted to carbohydrates. The comfort that comes from the carbs is an addiction, and nobody wants to talk about it. So, even though we know the best way to lose weight is to lower insulin and lower carbohydrate intake, we don't see it pushed by the mainstream media, and we certainly don't see it pushed by pharmaceutical companies. So, we have these new medicines that were discovered from Gila monster saliva, these incretins and all this stuff. Anyway, and they've been advancing, Tim, and I'm going to let you talk in a second. I'll get off my soapbox in a second. But they have developed these medicines, these injections, and some of them are pills now, that help treat diabetes because they lower blood sugar. But they have found that these patients in these studies were losing weight. And they weren't necessarily going for weight loss, but something has changed where these drugs have been increased in dose and rebranded under a different name, and now they're being sold for weight loss. Mm-hmm. So can you tell me about the evolution? You've been a medical endocrinologist for a number of years now. Tell me about the evolution of these incretin drugs, these GLP medications, how they were introduced, what their goal was for diabetes, and how weight loss has become a real driver in these drug sales. That's a big question. I just hit you with 10 questions.
Right. I don't know where to start with. So,
where do we start? So let's say these drugs became available 10 years ago. Victoza, or these early injections of these medicines that have become semaglutide, called Ozempic and Wegovy.
I don't know. Should we start with a medication, or should we start with 1972 when the Diet Coke came to American market? Or
I would love to hear about Diet Coke coming to America.
Right, or when they decided to get rid of the smoking and fields instead of the tobacco was, they put the corn instead of tobacco, right? And so now we have this high fructose corn.
Right, and now we have fructose, and they thought fructose was healthier than glucose, and they were wrong.
Right, so you brought a very, very important question of what are we fighting, what us being, citizens, being just the people, being just what are we fighting? It feels like sometimes we fight against the food industry because they want us to believe into things. And, sometimes when I talk to my patients, I say, imagine if you have a food company, what would be the single word you want to put on your product to make it sell better? And they say organic. I said, okay, next. Fat-free. Okay, and the third one, carb-free, or zero carbs.
Right.
And so, you're right. We were running from one to another. Fat is bad, cholesterol, blah, blah, blah.
Right.
Now we say carbs are bad. And so, and finally NIH and FDA, not so much, but NIH announced that aspartame is totally not good.
Right, the diet sweeteners, sure.
Right. And during all this revolution in the food, we end up having a lot of people, not only in the United States, really. I see it, around the world.
Yes.
Everywhere. Countries like China never had any problems with weight.
And they had rice.
Right. Yeah.
They had rice.
But
sure.
all of a sudden, obesity rate as of maybe 10 years ago became 10-15%.
Yeah.
What? Out of nothing?
Out of nowhere.
What happened?
Right.
And then you go to countries, maybe not so, rich countries like, I don't know, Turkey or something like this. By the way, number one country in obesity now is in the Middle East.
Where?
I'm not sure which one would be probably the biggest, the fattest one, but it's, I guess, Saudi Arabia.
Saudi Arabia is now experiencing obesity.
Right. We see.
I didn't know that.
We see what's going on in Mexico. Like, oh my God, why? What's going? Why all these people? Where eating the same kids? Children of the corn, they call themselves.
Yes,
right?
Children of the corn. Yes.
Right. So what is actually going on? Why is it so all of a sudden we got so big, so fat, and we eat all this? I guess if I can say a single word as an answer for that would be sugar.
Sugar. Yeah. It's hard to find anybody other than maybe the soft drink industry, and even they don't want to, that will tell you sugar's okay. Now, where soft drinks have come, they've said, well, we have 100 100-calorie can. So
Right.
it may be terrible for you, but there's only so many grams in there. So maybe it's not so bad in small doses.
Right. But if you think the sugar is a poison, that the sugar, the poison kind of multiplied, or poison square would be sweeteners, artificial sweeteners. And people say, well, I mean, what a big deal, it's good. It's 0 calories,
Right.
it's 0 sugar. I mean,
Right.
what can go wrong? What's wrong? And most of the providers, most of the doctors, including endocrine doctors, say, of course, if you're diabetic, you can drink your Coke, you can drink your Pepsi.
Right. I used to say
And
that,
stuff like this.
that the diet soda was okay, but what?
Right.
Tell me more.
But what? So sweet price comes with a price tag of. What are they doing? First of all, so many things they do now, and first of all, they directly and indirectly they make your body produce more insulin. What is
Just the thought of it, the cerebral aspect of it.
And directly, sweeteners go to the pancreas and say, sugar, and the pancreas, kind of without verifying, produce more of the insulin. And I see it a lot of times, and I see even healthy people now comes with so-called reactive hypoglycemia. Right? When they eat a lot of chips or something like this, and the sugar magically goes boom, 2 to 3 hours later.
Right.
And what's going on? I have a hormonal endocrine disease. Well, you don't. It's just a sugar. Let's say it's the sweeteners. That's what they do. And actually, you don't have to believe me. You
Right.
can just kind of experiment on yourself.
Sure.
So when you're on a good state, you're not hungry, you're doing fine. Drink a Pepsi or 0 Coke or whatever the.
Right.
But and then you will feel that about 30, 40 minutes later, you want to eat something.
There's the cravings.
Yeah.
Your sugar's going down and your
Sugars are going down.
and your appetite is going up.
Right. And at the same time, when you eat something and you drink those drinks as it's like instead of the water, you don't have that feeling of fullness. So you can eat more and more.
You can eat more.
Fascinating. At the same time, it's interesting, but they do something directly to that guts.
Mm-hmm.
And I'm sure you know where is the main hormone of happiness comes from.
Right.
They call it serotonin or serotonin.
Serotonin, yeah.
Right. And we would say, no, it comes from your belly. So when we eat, we feel good, right? So
Right.
what is that aspartame is doing is kill the production of that serotonin in your belly.
Really?
What?
I didn't know that.
Is that the reason we see so many people, and I swear, so many young people on the medications because they have a depression and anxiety? I don't have a good answer for
That's
that.
a whole nother world, Tim.
Right, but I feel like, it's not just somewhere on it. It's an NIH study confirmed that there is a significant difference of the production of the serotonin in people who drink or
The
eat
artificial
artificial sweeteners and the people who don't.
Oh, I'm
It's
so
a
glad.
big deal. It's a big deal, and that's one of the things. But the sweeteners are so cheap, and
Right.
they can stay on the shelves.
Right. Stable.
So they are now in every product on the market. And I'm not talking about, I mentioned chips. Yeah, like who would put the sugar in the chips? But the sweeteners are there. People usually say, I eat clean. I don't eat something bad. Okay, tell me. I eat salad, they say.
Right.
Okay, let's talk about salad. What do you put in this? Tomatoes, lettuce, I don't care. What do you put on your salad? Well, I'll buy salad dressing.
There's sweeteners in that.
Just like in that.
I'll be darned.
In that movie with old movie coming to America. Anyway, so this is where the poison comes from. That small amount on a dressing that you put in your salad that kills your feeling of
Satiety and fullness.
yes, that makes you eat more and come to buy more. And then
Right.
you getting addicted to that.
Yes.
And you eat more, drink more, and you consume more. Yes, right. That picture, right? And all that when you come to the store, any store, anywhere, and that's all you see on the shelves.
Yes.
Different brands, different colors, varieties, and all the sweeteners. And sometimes when you come to the market and trying to buy something and it says free, zero, no carbs, no carbs, no
Right.
carbs, no carbs, and you're like,
Right.
like for example, I come to find the milk. It says fat free, this free, that
Right.
free. No, I just want a milk.
I just want milk. Yeah, give me some real milk that we drank as kids and nobody was fat.
Right. So, a food industry is a big deal, and then they pushing us to eat that, and we all kind of hooked up to that, and so we all, and a lot of my patients say, the water is too boring. I want to drink Pepsi all day long,
Right.
or whatever. It's not about Pepsi or Coca-Cola or
Right.
Mountain Dew or whichever. Anyway,
Right.
And here comes the GLP agonist, just like you said. About 20 years now, I was enrolled in the clinical trials of liraglutide, or later known as the Victoza or
Victoza.
Saxenda, right? It was very interesting to see. Oh my God, you take that medication once a day, and the sugars miraculously kind of normalize. Wow, it's really it was a first experience. And it was really, and later, when I came to the States, I saw more of that, and it's a, really good medication. Now we have a kind of second generation of them, is Ozempic,
Right.
also known as OO.
was that? Yeah.
Yeah,
We're bombarded by these commercials.
and I can say probably a better version of second generation of them is Manjaro.
Yes, we're going to get to that.
Which is not only affecting the same receptors as an Ozempic,
GLP-1,
but also works on GLP-2 or GIP.
GIP.
Right. And so kind of double effect. And in the clinical trials, other than treating the diabetes, it normalized your hemoglobin A1C to the point when you're not diabetic anymore.
Right.
How many medications can do that?
Right.
So much so that it can be compared to the bariatric surgery. What?
What? Yeah, because that's it. The gold standard. Everything has always been measured, at least for the past few years, been compared to bariatric
Right.
surgery. That was the best you could do. And could you even get close with medicines? Well, now you can.
Yeah. By the way, I'm not being paid by any of those companies to say
neither
that,
of us
but it's a really good medication. And you prescribe it, you see a lot of side effects, more or less. Sometimes but it's interesting how much that medication is really, how many aspects in it, how many receptors in the body it covers, how many organs, including the brain, to the point that one of my patients first, mentioned something like, I used to have a voice in my head that says, eat sweets, eat sweets, eat sweets. With that medication, the voice is
quiet.
Gone.
Yeah.
It's gone. So
Yes.
I'm able to manage my diet much better. And then, somebody looked at that and said, what do you mean? That you were kind of addicted to the sweets and now you're not anymore?
Right.
Maybe we can use it in the people with addiction.
Maybe.
What? And now we use it in the people who are addicted to the alcohol.
Yeah.
So in other words, this is such an interesting medication. Comes with a price tag for sure.
Yeah. All right. So let's
right.
talk about that for a second. So the Ozempic rebranded at high dose at Wegovy, and this newer one, tirzepatide, both GLP-1 and GIP, maybe has even higher weight loss because it affects not only your satiety, it turns off that voice, gives you the fullness, it slows down your stomach so you can get full quicker, the fork goes down, You don't eat as much. And also, and this has been some of the controversy regarding an old drug called metformin.
Mhm.
Some people lose some weight on metformin.
Mhm.
People are trying to figure out how is it. Well, some people feel sick on metformin. They feel sick at their stomach, and the question has been, just because you feel sick, maybe that's part of the mechanism of action, at least in some people. So it's my understanding on these medicines, the Wegovy and now the Mounjaro, people actually feel sick. They have diarrhea or they have constipation. They have tummy aches. And that, at least in some people, may be contributing to why they're just not eating as much and they are losing some weight. So you're nodding your head. Does that sound right to you?
Yes. Speaking of metformin, one of the aspects is it's another very interesting and old medication, and there's so much controversy now going on. What is it doing? But one of the aspects, what metformin does in the body, it's kind of reduce the absorption of the sugars in the intestine. So maybe that would be one of the things.
Sure.
Why people usually not much, but sometimes they do lose some weight on that.
Right. And it's an old drug and it's a cheap drug. Now,
Yeah.
these new injections,
Mhm.
the Wegovy and the Mounjaro, they are expensive.
Yes.
And insurance companies don't like to pay for them. I think the cash price, if you can get it, like $1,500 a month or something like that, $1,000 to $2,000. Does that sound right?
Depends on the country, but yes, in the United States.
The United States, yes. And I believe they've become so popular, it's hard to even get them.
That is also true. That is also true. It some month it will go better, but yeah, it's still kind of issue of underproduction. So yeah, we're still dealing with, and let's say I have couple of friends work for this companies. They say we stop making anything else.
Yeah, they've gone
We just make
cranking
a
this stuff out.
We don't even send it to some of the European countries. We're just trying to cover United States.
The huge demand here. So here we have a medicine where you lose weight dependably. It turns off the voices in your head, the cravings.
Mhm.
Very effective. But let's talk about the difference between weight loss and fat loss. The weight on the scale is just one aspect of your health. We're all trying to get healthier or maintain our health. And as I alluded to earlier when we were talking about growth hormone and testosterone, maintaining muscle mass is crucial for our metabolisms and
Yeah.
avoiding diabetes and all this kind of increasing our sensitivity to sugar and whatnot. And it turns out that these medicines, you may see a lot of loss on the scale, but you see an enormous loss of muscle and lean body mass. Whereas for example, if you're losing weight on a low carb, high fat diet, you'll maybe lose 90% of the weight in fat, maybe 10% in muscle. It's my understanding that on these medicines, they're losing 50% of the weight from muscle. Is that your understanding?
No, I don't think so. I
Okay,
don't.
well, I think that's the case. And they don't like to talk about it. But I think it's because we're going to start talking about the side effects of these medicines. We've already said they're expensive and they're hard to get and they're injections and they have a cold chain. You can't keep them out in the sun. They need to be kept at least room temperature, if not cooler, for long-term storage. But the problem is you're losing muscle. And when you stop taking it, the cravings come back. And my understanding is almost everybody gains the weight back if that was the only thing they were doing to lose weight. What are your thoughts, Tim?
I'm not sure really about the muscle mass and what they do something with the muscle. But I mean, obviously, if you sit in front of the TV and injecting and just eating whatever, that's just not going to fly.
Certainly not long-term strategy.
Right. Even if you do take testosterone to make your muscles grow, I'm not really certain that your muscle will grow. In other words, there's nothing that can no medication that can substitute exercise.
For exercise, particularly weightlifting, correct. But any exercise is better than none, obviously.
Right. And I guess we can go there and talk some about the differences between the exercises, but just any of them are good. The more, the better. speaking of how long can you take that medication, and so far it's a newer medication, so we only have somewhere around 20 years of experience, maybe 25.
With the first generation, with these new generation, these phase 4, these ongoing safety are still ongoing. We don't know how safe they are long term.
Speaking of tirzepatide, probably
Right.
the one that hit the market in just a few years back. But again, the medication, before it comes to the market, it needs to be studied for somewhere around 8 years on average.
Sure.
How long can we take that medication? It's still kind of to be discussed, and to be. We would need to kind of work on that to see
Right.
how safe the medication is. If cravings are coming back, I guess yes. It's not really the switch in your head, and it's not really. I guess another interesting aspect of that medication that it's some people it works, and some people it's very effective, and some not so much. But when it's very effective, people can stop and stay off the medication for some time, a few months, and maybe a year. I guess the diet and changing diet would be the kind of main aspect. But again, medication does not only work on reducing the volume of your stomach and making you eat less. It works on the liver, on a pancreas, and the brain, and so many other aspects. So, and I mean, a lot of people mention that, I just don't want to eat junk food when I take the Ozempic,
Right.
for example, or these medications.
Right.
I'm not. So it was a lot of controversy about the hair loss, this loss, Ozempic face, Ozempic this.
Yeah, I was going to mention that's the next thing I want to talk about. Ozempic face is hollowing out the loss of fat and maybe muscle in your face and the butt. And if you're Caucasian, you may already be butt challenged here, and apparently it can get even worse.
I see a lot of people on that medication. I so far never seen any.
So it may be an exaggeration.
Maybe it's more in the California.
The California, right. Those are my thoughts too, because I've seen the pictures online of before and after, and some of them I really don't see much of a difference other than just what you'd expect from weight loss.
Right. Muscles, I don't have any data about the muscle loss.
I do have data on muscle, and you lose a lot of muscle. So I'm going to start wrapping this up, Tim. So I want some take-home thoughts about these new incretin, GLP-1, et cetera, medications. They're pretty reliable. They're very effective at weight loss. However, there are potentially side effects, and almost with any drug, somebody's going to have horrible reactions. I mean, some people, hey, it's a good drug for you. It's not a good drug for somebody else. So weight loss is dependable. However, the downside is, unless people make real lifestyle changes and dietary changes and start getting satiety, like we go into all the hormones, cholecystokinin, and all these things that come from eating slowly and eating more fat and more protein. Unless these lifestyle changes are made, if all you're doing is taking the Wegovy or the Mounjaro, the weight's going to come back.
Yeah.
And you may have lost some muscle. And I'm afraid as the cravings come back, people will stay on these medicines because they're virtually addicted to them. And I think, and so I'm concerned about the virtual addiction potential. The effect on overall body type and morphology, these potential face and fat distribution issues, and they may be cranking out Ozempic as fast as they can because they have a winner that a lot of people are going to become virtually addicted to without good long-term safety data yet.
Right. When you treat diabetes, you rely on some of the medications, and diabetes is a progressive disease, right? And so at some point, you can tell the patients, your main goal is to follow the diet and do the exercises, and that will control your diabetes, for sure. And you can see Tom Hanks and his changes, and how much he invested in his diabetes, and he has it, as if I'm not mistaken, under good control with just diet and physical exercises.
Okay.
But as a disease progresses, you unfortunately have to use some of the medications, and all of them have side effects. And the stronger the medication, as the rule of thumb, you have more of the side effects. If you compare GLP-1s to other medications, above mentioned metformin, GLP-1s are way more effective, but yes, they come with way more side effects. Metformin has some side effects as well, and a lot of people can just look at the metformin, right?
Right.
And you have this and that medications, and you have an insulin, but nobody wants to take insulin, and insulin have a lot of side effects.
Sure,
as well.
And that's an injection.
So what I'm trying to say is, yes, every medication is the medication. Sometimes you need to use it, and you see, a lot of success in that. And you compare it to the other drugs, and you find the GLP-1s are probably better than, a lot of other things. Like
what we've had so far.
What we have so far. But even them, have a lot of side effects as well. Even an insulin has can I say, yes, it's just a kind of blap, and a few years from now, we're not going to have that medication. No, I think it's a good drug. But we have to use it, what we should know what we do. Speaking of the medication, when you pee out your sugar,
yes.
Same here. Sometimes it's a very good drug, and it's not only help you with your diabetes, it also helps you with the heart problems and the kidneys, protects your kidneys. So in some instances, is oh my God. But yeah, it's probably not maybe the drug I want to give it to everybody as well.
Right. Well, I think you have eloquently demonstrated that these are difficult decisions. It's why we need smart medical endocrinologists like you who knows all these medications. So, Tim, I want to thank you for coming today. I have learned an awful lot. You're a wonderful friend and colleague, and I'm so grateful to have you in the community here to help treat our patients with all these hormone problems and endocrine problems, particularly that trouble with that we're having with diabetes and obesity here in our country.
Yeah, thank you so much. Thank you for having me. Yeah.
What a pleasure, Tim. Thank you.
Thank you.